Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. Farrukh Awan from the University of Texas Southwestern Medical Center in Dallas and Dr. Nicole Lamanna from Columbia University Medical Center in New York. They will be answering questions posed during a recent satellite symposium held at the Society of Hematology Oncology annual meeting on the role of BTK inhibitors in CLL. This episode is part of a larger educational program entitled Evolving Role of BTK Inhibitors in CLL, Sequencing, Combinations, and Novel Agents. For more information on the experts, along with a link to the complete program, including downloadable slide sets and an on-demand webcast from the live event, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
I think the first one is there any CLL patient population today for which one could justify a registrational trial where chlorambucil plus obinutuzumab is used as a comparator arm? So I can take that question. So I guess it depends on where you're doing the trial. If you want to do a trial in countries where ibrutinib or BTK inhibitors or venetoclax is not available, this would make perfect sense if half the group gets BTK inhibitors, preferably if there's a crossover arm. So I think you can justify it in that setting. Outside of that setting, you can also justify BR, you can also justify FCR or fludarabine rituximab, maybe even chlorambucil alone. But what happened to the concept of corporate social responsibility? I mean, would you go on a trial like that? And if you cannot justify that for yourself, how can we justify this for our patients? So I think in this country, unfortunately, I would consider that an unethical trial in this current state. Having said that, I recently recommended somebody to use lenalidomide for 17p deleted patients because in that country, they don't have access to BTK inhibitors and patients are taking BTK inhibitors off the black market or however they can get it. And then now we're looking at how we can combine fluconazole with venetoclax so we don't have to take a higher dose of venetoclax because people want to save money in resource-poor countries. And these are the tricks that other places use where patients don't have access to these novel therapies. And in that setting, you can justify a trial like this. But outside of that setting, no.
I don't think you could justify a trial like this. I think you could justify, as he said, if you needed to use the drug because you don't have other drugs because it's approved. So if you have chlorambucil and obinutuzumab and you don't have access to other agents, that's a different issue. But do I think that you could justify a trial with all these newer therapies? No, I think it's unethical to do so. I think we shouldn't be doing comparison. I actually don't participate in any of those studies.
Having said that, there's a lot of studies using BR as a comparison. I mean, come on, how long can we use this? Just because it's on the FDA list, does that make it the right thing to do? I'm sorry, there's no support from me, at least, for those kind of things.
Fair enough. All right. Do you anticipate ibrutinib and venetoclax becoming available? So the EMA just approved it over there. So I do suspect that. We expect to have approval for the oral combinations soon here in the US as well, so stay tuned.
So the next one is, what's the importance of overall response rate versus PFS with BTK inhibitors? So what's the end point? What's the objective? Again, there's an academic question and then there's a real life question. And now what's important for the patient? Does he really care about response rates and MRD? And the answer is absolutely not. Do I care? Absolutely not. I want what's best for the patient, and that is to make them live the longest amount of time, period. Now, if that is overall survival, great. I don't have that evidence. So the surrogate, like I said before, is PFS. Overall response might matter, or the speed to response might matter if they have bulky symptomatic lymphadenopathy and you want to get them into a remission. Once they're in a slight partial remission, it doesn't matter to me. I don't know if you agree or disagree.
Yeah, I think the one difference about BTK inhibitors, which is sort of switched our notion actually, when we gave chemoimmunotherapy, it was let's give the most toxic combinations we could get to eradicate the disease based on the agents we had, right? So get a complete remission in the bone marrow, because that translated into a longer response duration in PFS. That was in chemoimmunotherapy era. The BTKs flipped that, right? All of a sudden, you're having these dramatic, wonderful responses, melting of lymph nodes and organomegaly, improvement in blood counts, but you still had a little residual disease in the bone marrow, right? So it takes 2 years on a covalent BTK inhibitor, median time to a complete remission. The longer somebody's on a BTK inhibitor, they certainly can achieve a complete response, but it's a much slower to clean out the bone marrow, but patients are doing great. that sort of flipped our notion of everybody has to get a CR. You didn't have to. People could do really well on a PTK inhibitor as long as they had no adverse events and were maintaining compliance throughout the years. So that really changed our notion that you didn't have to necessarily achieve a CR or MRD negativity. The addition of doing that in the era of doing something time limited is a completely different issue, right? So if you're trying to get somebody off therapy, you want a good response so that then hopefully that will translate into a longer response duration, time to the next therapy, so on and so forth. So I don't think you need that, and then monitoring response for somebody who's on a covalent BTK inhibitor, you don't need to do. You would evaluate the response if there's a problem, or you're seeing that they're having an issue. Otherwise, you don't need to do their bone marrows and image them unless there's an issue. So response really doesn't matter.
Yeah, but for academic purposes, and I understand where this question is coming from, I think for approval purposes, academic purposes, you have to have some endpoints. This is where, we need to talk to the FDA, and if they keep using ancient endpoints, we will never may move the field forward. I think we have to think of this in a collective manner, and they have to come up with some sensible endpoints. Do patients really care about MRD? They don't even know, or even the physicians, half of them don't even know what that means and how to measure it. So is that really clinically relevant? Yes, it gets the drug approved, and yes, OR and PFS gets the drugs approved, but what's really important for the patient? And if that means that I can take a pill or 2 or 3, whatever, and be in remission for 20 years or 10 years, I don't really care. My quality of life is preserved, and maybe that should be the metric. And I think these are discussions that need to be had with people in the FDA rather than just following the books that are written by people in the FDA 20 years ago. This is my opinion.
Do you want to answer this?
In your mind, what are key differences between Zanu and Acala? This is, again, obviously we can refer to the trial that Nicole presented, but if you ignore that for a second and if you want our opinion, my preference has been that both are extremely well tolerated drugs for the most part. I have seen issues with bruising and bleeding with both of them. I have had more headaches with acalabrutinib, relatively easy to manage, occasional arthralgias, and with zanubrutinib, my experience has been more cytopenias, again, relatively easy to manage, and I typically tend to do max dose until I am stuck, but I can get away with growth factor support for the majority of those patients with neutropenia, and I tend to push through for most of my patients with thrombocytopenia because that's not that big a deal unless obviously you start getting into the 50s or lower. So most of my patients, that's what I've seen. I haven't seen that much diarrhea. Occasionally you see arthralgias with zanubrutinib.
Agreed. Initially, we used to make the distinction with Zanu and Acala regarding the PPIs. Obviously, there's a newer formulation of Acala, so I think that will obviously take that away. There is this dosing of once-a-day dosing or twice-a-day dosing with Zanu. I think many of us would like to see more data with the once-a-day dosing scheduling, but you can do that. So the question is, if you prefer something that's once a day versus twice a day, since they're both technically twice a day, maybe there's an appeal there, but I would love to see more data on the once-a-day dosing. Other than that, we don't perceive that there may be any differences with efficacy. I know there's a suggestion in the Zanu versus ibrutinib data. I think we need longer follow-up to see if that's really real or not. I don't think we'll ever see a Zanu to Acala head-to-head, as far as I'm aware.
Zanu versus ibrutinib data is looking pretty good. So one last quick comment and question is, you talked about transitions from BTK to alternative therapy. So if you have a patient who's progressing on BTK inhibitors, how do you handle those patients? So in 1 minute, we would like to get your input.
Typically, I will go to a ven-based combination.
But the transition, how does? Because you mentioned the transition might be tricky.
Yeah. No. So let's say somebody, if they're just having their white count slowly going up, I actually will stall for a while. So I'll evaluate their disease, but I actually will monitor them for a bit. So unless they develop cytopenias, I do not think you have to rush. The exception I talked about was sometimes with patients with rapidly progressive disease, complex karyotype 17p, p53, they'll tend to ramp up a lot quicker. Then you're sort of transitioning them over, and then I'll switch them to a ven-based combination sooner. I think clinical trials are always relevant, so of course both of us will usually put patients on clinical trials. But certainly I think not everybody who is starting to have some progression, I do not think all their cells are resistant, they're still benefiting from drugs. Sometimes I will actually keep them on therapy for quite some time.
Yeah, and just another minor point is that if somebody is truly progressing on BTK inhibitor actively, you stop the BTK inhibitor, disease flares off. So
Don't stop unless you're ready.
We have to, I guess, overlap with the new agent. So that's done off of a clinical trial.
Thank you very much, Dr. Awan and Dr. Lamanna, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Evolving Role of BTK Inhibitors in CLL, Sequencing, Combinations, and Novel Agents, and to download the slides associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.